So let me just make sure I heard your question right, but it's about commenting on the FDA and how they're looking at the whole concept of these types of things, and from a laboratory perspective, how that's going to impact us or something like that. Okay. Yeah, there's really no doubt about the role that the FDA is going to play, and already this concept of companion diagnostics is something that they're mandating from the pharmaceutical industries. And that if you look at the package inserts for some of the novel therapies that I mentioned, and what's in the applications for all of the newer ones that are being developed, there is a companion diagnostic component to each one of those drugs. Okay. The problem from a clinical lab perspective with that is, it's okay if in the package insert it says that you have to do some type of HER2 assessment, for example. I'm not sure that I'm okay with the package insert saying you have to do HER2 gene amplification with company X's product, right? And that's where we run into big issues, because that just happened with the BRAF inhibitor that came out from Roche. And the package insert for that drug specifically says you have to look for the BRAF mutation with the Roche molecular assay. And there are a lot of us that have BRAF assays we know outperform that assay. Right? Yeah, so the other part of all of that is the clinical validity of the assay as far as false positives and false negatives go away from the analytical validity. And this has become a huge problem for pathology in general, because we know that some of the things and practices that go on in the lab really have a high false positive rate. And that is not a good thing to have in the laboratory, especially when we're talking about therapeutic management of the patient. Because there are two outcomes to one of those results, whether it's false positive or false negative. The two outcomes is that somebody gets a therapy that they really didn't need to have, and they will experience whatever the side effects are of that therapy and the costs associated with that. Or somebody is denied a therapy that could potentially be life-saving for them. And so I'm not sure that the FDA has gone into specifics that I know of anyway, of saying that your clinical sensitivity and specificity has to be above 80% or 90% or whatever. But it's certainly a concern from our perspective. Yeah, thanks. That was a great question. Anything else? I can't see if anybody's standing at the microphone, so scream if you do. No? Okay, well, thank you very much.
Wasn't that fabulous? I am Marilyn Arsham. I'm the Director of Public Relations and Membership at AGT. I'm introducing today Dr. Barbara Goodman. She is the Director of the Clinical Cytogenetics Laboratory at Duke University and has been for the last 11 years. She received her postdoctoral training in cytogenetics and molecular genetics, and was a junior faculty member at Johns Hopkins. Dr. Goodman received her PhD from UCLA in experimental pathology in 1994. Dr. Goodman has worked as a cytogenetic technologist for several years in California before returning to school. We welcome Dr. Goodman on her talk on myeloma.